Today we will talk about ultrasound-guided invasive procedures performed by surgeons. Why do we use ultrasound guidance for these invasive procedures? Take the example of a central venous catheter. The position of the internal jugular vein usually varies, so palpation might not always correctly identify its location. Furthermore, whether there is a thrombus in the jugular vein cannot be determined by palpation. After the insertion of an introducing needle, it is impossible to know if the guide wire is heading in the correct direction without ultrasound. For patients in shock, if the carotid artery cannot be palpated, it becomes even more difficult to locate the jugular vein, especially during CPR when chest compressions are being performed. Without ultrasound guidance, placing the introducing needle correctly into the jugular vein becomes very challenging. For pericardiocentesis, the benefit of using ultrasound guidance is the ability to accurately determine the presence of pericardial effusion and to identify the location where the effusion is most prominent. It also helps pinpoint the site closest to the body surface and the best location for puncture. Real-time guidance allows for confirmation that the introducing needle is correctly inserted into the pericardial space. The evidence supporting the use of ultrasound guidance for central venous catheter placement is substantial. For the internal jugular vein, meta-analyses of large studies have shown that ultrasound guidance significantly reduces the occurrence of arterial punctures, hematomas, and the number of puncture attempts. More importantly, the time required for the procedure is greatly reduced. Additionally, ultrasound increases the chance of a successful puncture on the first attempt. Evidence supporting the use of ultrasound guidance for thoracentesis dates back to a 2010 study, which showed that using ultrasound guidance to drain pleural effusion improved success rates and significantly reduced the risk of accidental pneumothorax. As for ultrasound-guided paracentesis, a 2013 study demonstrated that it significantly reduces the risk of intra-abdominal bleeding and organ injury. Several large-scale studies have confirmed that ultrasound-guided pericardiocentesis significantly improves success rates. In a study involving 1,127 cases of ultrasound-guided pericardiocentesis, a 97% success rate was reported, with a complication rate of only 1.2%. Particularly regarding cardiac arrest due to the procedure. A 2019 study also found that ultrasound-guided vascular puncture does not increase the risk of infection. According to a BMC study, using ultrasound for central venous catheter placement does not increase the risk of catheter-related infections. Taiwan's CDC guidelines recommend the use of ultrasound guidance for central venous catheter placement to reduce the number of punctures and the risk of complications. Situations in which ultrasound-guided invasive procedures may be performed include vascular puncture, nerve blocks, abscess or fluid drainage, joint capsule puncture, tendon injections, thoracentesis, paracentesis, pericardiocentesis, lumbar puncture, and thyroid or breast biopsy for obtaining specimens. Before performing these procedures, it is crucial to complete some preparatory steps, such as ergonomic considerations regarding patient positioning, the operator's stance, the placement of the ultrasound machine, and the direction in which the needle should be inserted. Additionally, infection control, surface disinfection, and the establishment of a sterile field should be performed, and the operator should select the appropriate ultrasound probe and needle for the most efficient work. The patient's posture should also be considered to ensure comfort during the puncture. Finally, before starting the procedure, informed consent should be obtained from the patient, and a correct timeout process should be followed. To successfully complete the puncture, the most important thing is to align the ultrasound machine, the puncture site, the needle, and the operator in a straight line, known as the inline setting. This reduces the operator's burden. For instance, if a patient is undergoing a right internal jugular venous puncture, the ultrasound screen should be placed on the right side of the patient's abdomen near the liver. The operator should stand at the patient's right side, near the head, and the necessary puncture instruments should be placed on the operator's right-hand side. In this way, the doctor's eyes can focus straight ahead on the ultrasound screen while the needle moves straight and downward for an easier puncture into the blood vessel. The purpose of the inline setting is to reduce the physician's operational burden. Before starting the puncture, it is important to ensure proper infection control, including establishing a sterile field. The ultrasound probe should be covered with a sterile sheath, and sterile gel should be applied both inside and outside the sheath. The type of puncture equipment to be used should be chosen based on the specific needs of the puncture. For instance, when performing central venous access, an 18-gauge introducing needle should be used, along with a J-shaped guide wire and the corresponding CVC catheter. The choice of ultrasound probe depends on the depth and location of the target. The machine should be positioned opposite the operator and the target, allowing the operator to look straight ahead at the machine without turning their head to complete the puncture, which is called the inline setting. The patient's position, whether lying, sitting, or in a lateral decubitus position, should be determined by the type of puncture and what is comfortable for the patient. The principle of the puncture is based on the Pythagorean theorem, so the best needle entry angle is 30 or 45 degrees. When the angle exceeds 60 degrees, the image of the introducing needle becomes unclear on the ultrasound due to the Pythagorean theorem, so this should be avoided as much as possible. Next, let's go over some terminology definitions. Axis refers to the relationship between the ultrasound and the target. For blood vessels, when the direction of the blood vessel is perpendicular to the ultrasound, we call this the short axis. When the direction of the blood vessel is parallel to the ultrasound, we call this the long axis. If the axis of the ultrasound is oblique to the blood vessel, this is called the oblique axis. The relationship between the introducing needle and the ultrasound probe is called plane. Out of plane means that the ultrasound plane is perpendicular to the needle, so what appears on the screen is a dot-like image of the needle. If the ultrasound plane is parallel to the introducing needle, the entire needle will appear on the screen, known as in-plane presentation. For internal jugular vein central venous puncture, there are three approaches: out-of-plane short axis, in-plane long axis, and in-plane oblique axis. The key to the out-of-plane short axis is ensuring the operator can always locate the needle tip. The biggest difference between the needle tip and the needle shaft is that the tip does not have a reverberation artifact. Therefore, on the ultrasound, the needle tip appears as a small white bright spot. If you see a comet-shaped reverberation artifact, the image is showing the needle shaft. The best condition for achieving this effect is when the ultrasound is perpendicular to the needle. Therefore, if the needle entry angle is set at 30 degrees to the skin, the ultrasound probe should be perpendicular to the needle, meaning the probe will not be perpendicular to the skin, but tilted back at an angle of 120 degrees to the skin. This ensures that the ultrasound is fully perpendicular to the needle and can present the best image of the needle tip or shaft. The pearls of the in-plane long axis approach is to align the ultrasound, the introducing needle, and the blood vessel in the same plane. If the needle entry direction is oblique, the entire introducing needle cannot be visualized. If the entire blood vessel cannot be displayed on the screen, it becomes difficult to confirm the position of the needle tip, increasing the risk of hematoma. If the introducing needle is not positioned directly under the ultrasound, it may cause a slice thickness artifact, meaning that although the needle is off to the side of the ultrasound, the image may falsely suggest that the needle has entered the blood vessel. In 2019, a study was published showing a series of ultrasound images from A to E, demonstrating that only in image C did the needle tip actually enter the blood vessel. However, due to the slice thickness artifact, the ultrasound images from all 5 points created the false impression that the needle had entered the blood vessel. So, how exactly can we determine whether the introducing needle is inside the blood vessel? The most important thing is to ensure that the needle insertion point is located directly beneath the ultrasound. By adjusting the focus of the ultrasound beam directly above the blood vessel, we can take advantage of the ultrasound's converging and diverging properties. If the introducing needle is not positioned directly above the blood vessel, the needle will not be visible on the ultrasound image. Another method is to minimize the angle between the introducing needle and the skin, allowing the ultrasound to travel as perpendicular as possible to the needle. This helps us use the strength of the reflected shadow to determine whether the needle tip is directly beneath the ultrasound. There are specially designed ultrasound probes available that can combine both the out-of-plane short axis and in-plane long axis views. This allows us to confirm the position of the introducing needle in relation to the blood vessel as it is inserted. As the needle advances further, we can observe the full image of the needle on the left side of the ultrasound screen to confirm whether it has successfully entered the blood vessel. In this scenario, the brightness of the introducing needle on the screen indicates that the needle is directly beneath the ultrasound. Another case is when the needle is inserted entirely to the side of the blood vessel, resulting in a much dimmer image of the introducing needle on the ultrasound. Recent studies have shown that the in-plane oblique axis is a highly effective technique. It combines the advantages of the out-plane short axis, which allows simultaneous detection of both the artery and the vein, with the benefits of the in-plane long axis, which enables visualization of the entire introducing needle under ultrasound. This combination allows for a more accurate determination of whether the needle has successfully entered the blood vessel, while also avoiding venous injury or accidental puncture of an artery or nerve. Let's move on to discussing the specific topic. For internal jugular central venous catheterization, there are 4 main steps: pre-scan, poke, indwelling, and post-scan. 1. Pre-scan. The key is to select the correct blood vessel, ensure it is healthy, locate the optimal insertion site, optimize the machine settings and positioning, and confirm that there is no pneumothorax or hemothorax. Ultrasound helps determine the relative positioning between the internal jugular vein and the carotid artery. Initially, the internal jugular vein runs parallel to the carotid artery, but as it progresses toward the heart, it increasingly overlaps with the artery. Lower insertion points increase the risk of accidentally puncturing the artery. Besides understanding the relative positions of the internal jugular vein and carotid artery, it's also important to assess whether the vein is narrowed or obstructed. On ultrasound, the upper left image shows a normal internal jugular vein, appearing flat and oval-shaped. The upper middle image shows a stenosed vein, which appears round and lacks blood flow in color mode. The upper right image shows a severely distended vein, suggesting possible proximal obstruction, such as a thrombus or tension pneumothorax, which must be addressed first. The lower images show thrombotic blockages in the vein. The lower left image shows an acute thrombus, while the lower right image shows a chronic thrombus with fibrous dissolution along the edges. These situations should be identified before the puncture, and ultrasound is essential for early detection. We recommend placing the ultrasound machine directly in front of the operator to avoid the need for the operator to turn their head to look at the screen, which can greatly increase the efficiency of the puncture. In the image on the left, the operator has to turn their head to the left to view the ultrasound machine's screen during the puncture, making the procedure more difficult. The way to hold the ultrasound probe is a universal technique. Remember, when performing an internal jugular vein puncture, the probe's point should be oriented toward the patient's left side or head. At the same time, on the ultrasound machine, the left side of the screen represents the patient's left side or the direction of the patient's head. Since the internal jugular vein is very easy to compress, remember to place the probe gently on the patient's neck without pressing too hard, as this may collapse the vein. Also, before the puncture, ensure the patient does not have a pneumothorax or hemothorax. Use ultrasound to confirm that the fourth intercostal space shows normal pleural sliding. If there is no normal pleural sliding in the patient's intercostal space, switch to M mode to check for a lung pulse. If there is no lung sliding and no lung pulse, and the patient is in shock, assess whether the patient has tension pneumothorax. Further information related to lung ultrasound is available in the QR code provided for reference. 2. Poke. It is important to estimate a safe needle depth and always be aware of the needle tip's location during insertion. If the needle appears to be inside the vessel on the ultrasound but does not produce blood return, it could be due to a slice thickness artifact, creating the illusion of needle entry into the vessel. We've covered these key points earlier. The neck's curvature requires the ultrasound probe to adhere closely to the neck at an approximate 40-degree angle for scanning. If the needle insertion direction does not follow the scan's trajectory, but instead goes straight down, it will result in an unsuccessful puncture. This situation often occurs with inexperienced or nervous operators, so be cautious. 3. Indwelling. After successfully inserting the needle into the internal jugular vein, the next step is to insert the guide wire. Ultrasound is used to check whether the guide wire is moving in the correct direction. The operator must also be careful when switching the needle from the right hand to the left hand after setting down the ultrasound probe to avoid accidentally pulling the needle out of the vein and causing tissue or arterial injury. To avoid placing the CVC in the wrong position, once the guide wire is placed in the internal jugular vein, a rapid scan should be performed to check if it is positioned correctly and heading toward the brachiocephalic vein. Due to the obtuse angle between the internal jugular vein and the subclavian vein, about 107 degrees, there is a chance that the guide wire could accidentally enter the subclavian vein. When scanning the guide wire, if it is found to be heading in the wrong direction, you should pull it back into the internal jugular vein, ask the patient to perform shoulder flexion, and the internal jugular vein will align more sharply with the subclavian vein, allowing the guide wire to pass smoothly into the brachiocephalic vein. This principle also applies to subclavian central venous catheterization. Always confirm the guide wire's trajectory before using the dilator, since the ultrasound probe must be set down when handling the guide wire. If the operator lacks stability or the patient suddenly moves, the needle could puncture through the internal jugular vein and enter the carotid artery. Thus, it's crucial to ensure the guide wire's position before using the dilator. Once the guide wire is correctly placed into the brachiocephalic vein and the dilator and CVC are inserted into the internal jugular vein, perform a post-placement scan to check whether the CVC is properly located in the superior vena cava and to rule out iatrogenic pneumothorax or hemothorax. The benefit of using ultrasound is that the position of the CVC can be monitored in real time to detect any directional errors within the internal jugular vein. A microbubble tester can also be used to determine whether the CVC has been successfully placed in the superior vena cava. The procedure involves mixing 1 cc of air with 9 cc of saline solution to quickly form microbubbles, which are then injected into the CVC. If microbubbles appear in the right atrium within 1 second, it indicates successful placement of the CVC in the superior vena cava. However, if the appearance of microbubbles takes longer than 1 second, it may suggest that the CVC is kinked or placed in an incorrect location, such as the left subclavian vein. The central venous catheterization of the subclavian vein can mainly be divided into 2 approaches, the infraclavicular approach and the supraclavicular approach. The primary difference between the two is that the target of the infraclavicular approach is the axillary vein, while the target of the supraclavicular approach is the subclavian vein. When the patient is in shock, the subclavian vein tends to be more dilated than the axillary vein. Additionally, the subclavian vein runs straighter compared to the axillary vein. The likelihood of pneumothorax caused by failed puncture is similar between the 2 approaches. About the out-of-plane needle approach in ultrasound-guided thyroid biopsy, center the probe directly on top of the target. Check the distance from the skin to the target in order to judge the appropriate needle angle to use. For superficial targets, the needle will be placed with a flatter angle, and for deeper targets, the needle will be placed with a steeper angle. Note that most probes have an indication of a center point on the long side, which is helpful for optimal placement of the needle. Make sure to allow at least 1 centimeter distance between the edge of the probe and the needle entry to allow space to change angle as needed in order to reach the target. Place local anesthesia accordingly before starting sampling. Pay close attention to where the needle appears on the screen as it crosses the field. If you see the needle appear above the target, you need to pull back and reposition the needle with a steeper angle. Or if the needle is coming across the field below the target, pull back and reposition the needle and adjust to a flatter angle until you see the needle crossing the field inside the target. At this point, start the sampling with to and fro motions tailored to the size of the target. The needle is only visible as a point on the screen as it travels across the field of vision. Advantages of perpendicular needle placement include a shorter distance from the skin surface to the target and more flexibility in getting into tight spaces limited by adjacent structures such as large vessels and bone. The main downside is the lack of visibility of the needle until it crosses the ultrasound field. The in-plane needle approach in ultrasound-guided procedures offers the advantage of continuous visibility and control of the needle tip, though it requires a longer needle path compared to the perpendicular approach. However, maintaining the needle within the narrow ultrasound field can be challenging and demands practice. Indications for emergency pericardiocentesis include unstable vital signs, shock, or cardiac arrest caused by pericardial effusion. Pericardiocentesis for unclear causes of pericardial effusion or for differential diagnosis is not an emergency indication. There are no absolute contraindications for emergency pericardiocentesis, but relative contraindications include infections at the puncture site, patients on anticoagulants, or active bleeding due to aortic dissection leading to cardiac tamponade. In such cases, pericardiocentesis may not solve all problems, and correcting coagulopathy or performing emergency thoracotomy for hemostasis may be necessary. The first step in emergency pericardiocentesis is to become familiar with the puncture sites, corresponding scanning methods, and the positioning of the ultrasound probe. If the subcostal 4-chamber view is chosen, the probe point should face the patient's left side, and the ultrasound screen's point should also face the patient's left. The needle is inserted near the point of the probe, and it will appear on the side of the screen where the point is located. If using the apical 4-chamber view, the probe point faces the patient's left side, as does the screen's point. The needle is inserted near the probe's point, and it will appear on the side of the screen where the point is located. For the parasternal long-axis view, the probe point faces the patient's right side, and the screen point also faces the right. The needle is inserted from the side without the point, and it will appear on the side of the screen without the point. The second step is selecting the appropriate window for puncture. Generally, the usable windows for pericardiocentesis include the aforementioned parasternal long-axis view, apical 4-chamber view, and subcostal 4-chamber view. The choice of window depends on which site has the most pericardial effusion and the fewest obstructions, such as no lung interference. Using the subcostal 4-chamber view is a more traditional approach. Its advantage is that the puncture can be performed simultaneously during chest compressions in CPR. However, disadvantages include the needle passing through the liver, and the needle needs to penetrate deeper, making it easier to lose track of the tip and risk heart injury or iatrogenic pneumothorax. The parasternal long-axis view has the advantage of the shortest needle path, but the disadvantage is the need to localize the internal mammary artery first to avoid damaging it. Additionally, this method may not allow drainage of the deepest pericardial effusion. The apical four-chamber view has the advantage of a short needle path and can also be used during CPR chest compressions. The downside is that the needle path may pass through the lungs, leading to pneumothorax. Once the appropriate method is chosen, the third step is using the in-plane needling technique to insert the needle into the pericardial cavity. The key is to keep the needle tip visible on the ultrasound screen at all times until it enters the pericardial cavity. The fourth step is using agitated saline to confirm the needle tip's location. This is only necessary for the subcostal four-chamber view, where the needle may need to penetrate as deep as 10 to 15 centimeters, making the tip hard to visualize on ultrasound. Injecting about 5 cc of agitated saline can help locate the tip through the high echo signal it creates on the ultrasound. Remember that because the patient already has life-threatening cardiac tamponade, once the needle tip is confirmed in the pericardial cavity, do not inject more agitated saline. The fifth step is to insert a guide wire into the pericardial cavity and use a scalpel to make an incision on the skin surface. This step is crucial because elderly patients may have tough skin, and failing to make an incision before using a dilator may cause the dilator to get stuck on the surface, bend, or kink. The sixth step is using a twisting motion to guide the dilator along the guide wire into the pericardial cavity. Avoid excessive force to prevent the dilator from bending and causing incorrect placement. The seventh step is choosing the correct IV administration set. After successfully placing the drainage catheter into the pericardial cavity, connect it to a Luer slip-type IV administration set. Avoid using a Luer lock connector, as the strong suction from the vacuum bottle could break the sealed connection and cause the vacuum effect to fail. The eighth step is inserting the drainage catheter into the vacuum bottle and securing it properly. The key points of the entire procedure include avoiding damage to the internal mammary artery when using the parasternal long-axis view, preventing iatrogenic pneumothorax when using the apical four-chamber view, and ensuring the needle tip does not get lost, which could result in heart injury or iatrogenic pneumothorax when using the subcostal four-chamber view. Using ultrasound to extract pleural effusion or ascites can be done in two ways: static ultrasound-assisted and real-time dynamic ultrasound-guided method. The drawback of the static ultrasound-assisted method is that the patient must maintain the same posture and cannot move. Therefore, if the patient becomes restless due to pain, or if the location of the scan differs from the actual puncture site, there is a high risk of organ injury or bleeding. Real-time puncture under ultrasound guidance is a safer method and can be categorized into two techniques: out-of-plane and in-plane. A comparison between static ultrasound-assisted and dynamic real-time ultrasound-guided method is as follows. The static ultrasound-assisted method is more suitable for patients with a large amount of pleural or peritoneal effusion. Since ultrasound is not used during the puncture site needs to be marked with ultrasound beforehand. During the puncture, the patient must be asked to hold their breath and avoid any extra movements to prevent inadvertent injury to other organs or blood vessels. The dynamic real-time ultrasound-guided method is suitable for puncturing smaller amounts of pleural or peritoneal effusion. Since it involves real-time ultrasound-guided puncture, there is no need to mark the puncture site. However, to effectively use the technique of dynamic ultrasound-guided puncture, deliberate practice is required to precisely control the position of the needle tip. When extracting peritoneal effusion, care must be taken to avoid inadvertently injuring the inferior epigastric artery, superficial epigastric artery, and ascending branch of the circumflex epigastric artery. The inferior epigastric artery runs directly above the peritoneum, so if it is accidentally punctured, it can lead to significant intra-abdominal bleeding. For thoracic puncture, care must be taken not to injure the internal costal artery. The internal costal artery is located at the lower edge of the rib, but there is an anastomosis at the costal angle. Therefore, when positioning, ultrasound must be used to ensure that there are no bridging vessels at the puncture site to avoid complications such as massive hemothorax. Regarding nerve block, the most practical scenario for surgeons is post-operative pain management after thoracic or abdominal surgery. Common techniques include ESPB and SAPB. The SAPB method involves injecting anesthetic into the space between the upper and lower layers of the serratus anterior muscle fascia, producing anesthetic and analgesic effects. The SAPB method is primarily suitable for lateral thoracic anesthesia and pain relief, such as in the case of lateral rib fractures or post-thoracotomy pain. The steps for performing SAPB involve placing the ultrasound probe vertically at the intersection of the patient's mid-axillary line and the fourth intercostal space, locating the latissimus dorsi, serratus anterior, and ribs mixing 10 ml of lidocaine with 10 ml of saline and injecting 10 ml each into the upper and lower fascia layers of the serratus anterior muscle. ESPB, on the other hand, involves injecting a local anesthetic above the transverse process of the vertebra. The anesthetic spreads along the fascia, achieving anesthesia and pain relief across 3 dermatomes above and below, making it suitable for fractures of the posterior, lateral, or anterior ribs. ESPB, when injected at the transverse process of the lumbar vertebrae, can achieve pain relief for the abdomen. In the afternoon's practical session, we will have you practice subclavian vein puncture, puncture in difficult internal jugular vein situations, and pericardial effusion drainage puncture techniques.